Swayam Prabha. Digital India. Educated India.
Hello, I am Anju Kagal and today I am going to be telling you about malaria. The learning objectives of today's lecture are to know about the causative agents and vectors of malaria, the epidemiology of the disease, the life cycle of Plasmodium species, the morphology of different species of Plasmodium, the pathogenesis and clinical presentation, complications, laboratory diagnosis and treatment of the disease. The word malaria is derived from the Italian word mal meaning bad, area meaning air. The parasite was discovered by Charles Laveran and Sir Ronald Ross demonstrated a sexual phase in the female Anopheles mosquito, a sexual phase of the malarial parasite. Now, let us look at the names of the parasite which is known to cause malaria. The genus is Plasmodium and the most common species are Plasmodium vivax, falciparum, ovale, malariae and the newer Plasmodium knowlesi. Plasmodium vivax is synonymous with benign tertian malaria, falciparum with malignant tertian malaria, ovale with ovale tertian malaria. P. malariae is synonymous with quartan malaria and knowlesi is synonymous with quotidian or simian malaria. Now, these terminologies have been given depending upon the periodicity of the fever. So, tertian malaria tends to peak every 72 hours, quartan malaria more than 1 day more than 72 hours and quotidian occurs every day. Plasmodium vivax and falciparum are the most common ones seen in India. Each year, there are approximately 200 to 300 million cases of malaria reported worldwide and it kills over 1 million people every year. And as you can see, India is one of the places where malaria is quite predominant. Transmission of the parasite is by the female Anopheles mosquito, which needs 2 blood meals for its eggs to hatch. The male Anopheles mosquito is a very happy-go-lucky fellow who feeds on nectar and fruit juices. The common female Anopheles mosquitoes which are known to transmit the disease in India are Anopheles culcifacies, Anopheles stephensi, Anopheles fluvivitalis and Anopheles sundiacus. All these are found in different regions in our country. Transmission, besides occurring by the vector, can also rarely be transmitted by blood transfusion and by syringe transmission in drug addicts. A person who is suffering from Plasmodium falciparum infection, the parasite can survive for up to 1 year in the body. For P. vivax and ovale, it can survive for 3 years, and for P. malariae, it may persist up to 30 years. The life cycle of Plasmodium shows an alternation of host, and the two hosts involved are man and the mosquito. And it also shows an alternation of generation, meaning there is an asexual cycle as well as a sexual cycle. The asexual phase occurs in man, and therefore, man is considered the intermediate host. The sexual phase occurs in the mosquito, and the mosquito is called the definitive host. Now, let's look at the life cycle in man. All right. For this, I want you to try and use your imagination a little bit, look at the pictures, and I will take you through the phases of the mosquito passing through the human body. So, it is basically the sporozoite which is injected by the mosquito into the human host. Now, these sporozoites are very slim and they enter the bloodstream, from where they tend to go to the hepatic cells. Over here, they get converted into the schizont. Now, some of these sporozoites are very lazy, the schizont is very lazy. It is like it sort of got hypnotized by the liver, and these are the lazy fellows who will remain dormant in the liver, and therefore, they are called hypnozoites. So, remember, they have been hypnotized by the liver and they are lying in the liver, lazy fellows. The other schizonts tend to multiply, they mature, and you get thousands of merozoites which are produced. Now, in this liver cell, these merozoites, as they keep increasing in size, finally, it is like a balloon where you keep filling air, and when you fill too much air, it bursts open. Similarly, as the merozoite keeps filling the hepatic cell ruptures. Now, these merozoites, some of them are very adventurous, and what do? They look at the bloodstream and they see these flying saucers which are the RBCs, and because they are adventurous, they jump onto these RBCs. Now, within the RBCs, these immature merozoites undergo transformation. They become kids, that is, they become the trophozoite form. As they mature into the teenager stage, they become the amoeboid form. And what do teenagers do? They go for parties, and therefore, you can remember that it becomes an amoeboid form. Imagine this trophozoite form dancing. So, it becomes an amoeboid form. Now, after its teenage years, it then matures into the schizont. Now, this schizont is now, let us presume, somewhere in his 20s, and the schizont decides that now he has to continue his cycle and he becomes a merozoite. Again, the schizont multiplies, produces thousands of merozoites. Now, these merozoites which are produced, they rupture the RBCs. Some of them reinfect the RBCs, and some of them go into the erythrocytes and then these erythrocytes go into the internal organs where they mature into gametocytes, and these gametocytes are then taken in by the mosquito. Let us look at the cycle in the mosquito. The gametocytes which are ingested by the mosquito, part of its blood meal, are two types, the macrogametocyte and the microgametocyte. The macrogametocyte is the female and the macrogametocyte is the male. Now, from the macrogametocyte, it gets converted into a macrogamete, which is the male gamete, and this starts producing flagellae on its surface. These flagellae get dislodged, a process called exflagellation, and they go and fertilize the macrogamete. Once the macrogamete is fertilized, you get the formation of a zygote. This zygote then matures into an ookinete. Now, these are all present within the gastrointestinal tract of the mosquito. Now, this ookinete escapes from the intestine into the coelomic cavity, and you get the formation of an oocyst. Within the oocyst, you have sporozoites, and as these sporozoites multiply, they break through the oocyst and they are again transferred to the salivary gland of the mosquito. And when the mosquito has its next blood meal, it deposits these sporozoites into the host bloodstream. All right. So, now we have covered the cycle in the human host, we have covered it in the mosquito. Just to tell you a few more details about the life cycle in man, the sporozoites tend to reach the liver within half an hour of being injected, and in the liver, when they undergo multiplication, it is called the tissue schizont stage. After the tissue schizont stage, the schizonts enlarge, they divide to form thousands of merozoites, and this process takes about 1 to 2 weeks. Remember, I told you some of these schizonts have got hypnotized by the liver and are called hypnozoites, and these can persist in the liver for many weeks to months, and this is especially seen with Plasmodium vivax and Plasmodium ovale. And therefore, with these two species, you have to be careful to monitor the patient in case he has a relapse. So, what happens to the remaining merozoites? The ones which haven't got hypnotized by the liver. So, these merozoites which are produced once they are released from the liver. These are, remember, the adventurous merozoites. These bind to the RBCs where they get enveloped into a vacuole. Now, once they enter the RBCs, they mature into the early trophozoite or ring form. Then they have the late trophozoite. In the case of P. falciparum, they will appear like 2 ring forms, and in the case of Plasmodium vivax, they are like amoeboid trophozoites. These then mature into immature schizonts and mature schizonts with merozoites again. Now, these merozoites which are produced in the RBCs, once they are present in very large numbers, they will rupture the RBCs, and some of them will reinfect new RBCs, and others are carried by the RBCs to the internal organs where they mature into gametocytes. And this is what the gametocyte for Plasmodium falciparum will look like. This is the microgametocyte, which has a diffuse, which is a little longer than the macrogametocyte and has diffuse nuclei, and you have the macrogametocyte, which has the nuclei condensed in the center. Now, remember when I had told you about transmission of the Plasmodium. The mosquito transmits sporozoites, but in the case of blood transfusion and syringe transfusion, it is actually the blood or the erythrocytic stage which is inoculated directly in these patients. So, these patients miss the cycle which occurs in the liver. Now, this is what the various forms look like in the different species of Plasmodium. You have the early trophozoite or ring form. In the case of Plasmodium vivax, it occurs as a single ring. Amoeboid form in P. vivax, immature schizont, the mature schizont with merozoites, and the microgametocyte and the macrogametocyte. If you notice, it is only in P. falciparum that the micro and the macrogametocyte look different. All right? They are banana shaped or spindle shaped. During this erythrocytic stage, you can also get the formation of an acole in the case of Plasmodium falciparum. You can get double rings, which are a feature of Plasmodium falciparum. You can also get hemozoin pigment. In P. vivax, this hemozoin pigment is very minute, they are like little dots called Schuffner's dots, and in the case of Plasmodium falciparum, they are referred to as Morer's clefts. So, once again, to revise, the Plasmodium falciparum micro and macrogametocyte look distinctly different from the rest. These forms, that is the amoeboid trophozoite, the immature schizont and the mature schizont with merozoites, are not visible in the peripheral blood smear in the case of Plasmodium falciparum. In the case of Plasmodium vivax, all the forms can be seen in the liver, can be seen in the blood smear. In the case of P. falciparum, it is only the early trophozoite and the macro and microgametocyte which can be seen in a peripheral blood smear. Pathogenesis. Liberation of the parasite and erythrocytic material into the circulation causes fever. In addition, repeated destruction of the erythrocytes can give rise to anemia. And finally, this rapid turnover of RBCs can result in splenomegaly. In addition, where Plasmodium falciparum is concerned, we have additional factors which add to the pathogenesis. Now, the RBCs which are infected with Plasmodium falciparum tend to develop knobs on the surface, and these bind to the vascular endothelium. When there is cytoadherence in the vascular endothelium, then more and more RBCs collect at the site, resulting in occlusion of blood flow. In addition, very often the RBCs tend to form rosettes. This also adds to the occlusion of the capillaries in the internal organs. The main signs and symptoms are fever, anemia and splenomegaly. The incubation period varies from different species from 12 days to 28 days depending upon the species of Plasmodium. Now, the periodicity of the fever tells us which parasite could be causing the infection. The tertian form, that is fever which is occurring from on every third day is seen with Plasmodium falciparum as well as Plasmodium vivax and Plasmodium ovale. Quartan is seen with Plasmodium malariae. All right. So, this is the periodicity of the fever. Most often you see this typical periodicity, but in the case of falciparum, it is known to start having the peaks even earlier than 3 days. The fever is typically seen as occurring in 3 stages: the cold stage, the hot stage and the sweating stage. In the cold stage, the patient starts with rigors, chills and a severe headache. This usually lasts from 20 minutes to 1 hour. The hot stage, the temperature rises to the maximum with tachycardia, hypotension, patient may have cough, retroorbital pain, backache, nausea, abdominal pain, vomiting, diarrhea and altered sensorium depending on the severity of the disease, and this takes about 1 to 4 hours. The sweating stage, here the patient sweats profusely, temperature, headache and other symptoms decrease and the patient develops marked fatigue and finally sleeps. This period of sweating stage usually lasts for 2 to 3 hours. The anemia is a hemolytic, normocytic, normochromic and occurs after a few paroxysms of fever. Splenomegaly occurs a few weeks after the febrile paroxysms and as a result of rapid RBC turnover and hyperplasia of the reticuloendothelial system. The complications which occur are relapse because of Plasmodium vivax and Plasmodium ovale, and this is because of the hypnozoites, if you remember. Recrudescence is recurrence of the fever which is seen with all 4 species. Plasmodium falciparum is notorious for causing cerebral malaria or Blackwater fever. Plasmodium malariae and knowlesi can cause nephrotic syndrome or even renal failure, and chronic complications present in the form of tropical splenomegaly syndrome. So, relapse can occur anywhere between 3 weeks to 1 year, and recrudescence is something which is seen as a result of treatment failure. And therefore, because there is treatment failure, the parasite persists in the RBCs and starts producing fever even after treatment is complete. Cerebral malaria, I told you, as a result of the sequestration of the RBCs within the internal organs, within the capillaries of the internal organs, and here you can see a picture of the RBCs showing little knobs on their surface. So, usually the patient has diffuse symmetrical encephalopathy characterized by generalized convulsions. In addition, there may be retinal hemorrhages, neurological sequelae and coma in many patients. Mortality is seen in up to 20% of patients. Blackwater fever is as a result of rapid and massive intravenous hemorrhage of parasitized and non-parasitized RBCs, which results in hemoglobinemia and hemoglobinuria. Clinically, the patient has high fever, vomiting, jaundice and passage of dark color or blackish urine. It is as a result of autoimmune response to multiple attacks in patients with P. falciparum infection who have taken quinine irregularly and inadequately. And it is believed that there may be predisposing factors like excessive cold, excessive physical activity or alcohol abuse. Some other complications: algid malaria, pulmonary edema and ARDS syndrome can occur with P. falciparum, renal failure as a result of sequestration of RBCs in the renal vasculature leading to tubular necrosis, jaundice due to hemolysis, hepatocyte injury and cholestasis. The laboratory diagnosis of malaria is very important considering that it is seen in our country in such large amounts. Microscopy so far was the method of choice in which we examined thick and thin smears. These are gradually being replaced by the rapid diagnostic tests which either detect the antigen, enzyme, or you can do another rapid test which is called the quantitative Buffy coat test, QBC. Molecular tests consist of PCR and real-time PCR for identifying the parasites. Now, let us look at each of these in detail. Microscopy is considered the gold standard for diagnosis because this is where we actually see the parasite. The sample which is collected is a peripheral blood smear, or sometimes when it is difficult to diagnose the condition, especially in chronic malaria, one may have to resort to doing a bone marrow aspirate or a bone marrow biopsy. For peripheral blood smear, we can prepare a thin smear or a thick smear. These are then stained with Leishman stain or Giemsa stain or with field stain, and the smears are observed under oil immersion lens. A thick smear has the advantage of being able to look at the smear in a rapid form. You can actually see the smear in a short period of time, all right. But the disadvantage is that before we stain a thick smear, we have to dehemoglobinize it, and therefore you do not see the parasite within the RBCs, and it requires an expert to be able to really visualize the parasite. The advantage of microscopy is that you can identify species based on the morphology. You can quantitate the parasite, which helps in determining whether the patient is likely to get complications. So, a parasitemia of more than 20% in P. falciparum would indicate that something needs to be done to prevent complications in these patients. It also helps in assessing response to treatment. The disadvantage is that it needs experienced people to look at the smear, and the sensitivity is very poor. You need to have more than 200 parasites per microliter of the blood sample to see the parasite. And this is what they look like. In P. vivax, you would look for a single ring form. In P. falciparum, you would look for double ring form and maybe egg hole formation. Amoeboid form of P. vivax is seen in the peripheral blood smear. In P. malaria, it appears like a band. The late trophozoite, immature schizont and mature schizont is not seen in the peripheral blood smear of P. falciparum, and the gametocytes of all species are seen in the peripheral blood smear. These are some of the pictures of peripheral blood smear. P. vivax showing you a single ring form, P. falciparum showing you double ring forms, amoeboid forms seen in P. vivax, gametocytes rounded in P. vivax, spindle shaped in P. falciparum. Now we move on to the rapid diagnostic tests. I will be talking about the quantitative Buffy coat test. This is a very sensitive test. 90% of the parasites can be identified. Over here, after a finger prick, blood is collected in a capillary tube which is coated with acridine orange. Acridine orange is a fluorescent dye which will stain the parasite. The capillary tube is centrifuged, and the parasite, if it is stained with the acridine, the parasite, if it is present, is stained with acridine orange and is observed as fluorescence. So, after you have centrifuged, the parasite is found in mainly the lymphocytic or the granulocytic area, and on the right you can see some of the pictures of the fluorescent parasite. In the other rapid diagnostic tests, we have the immunochromatographic tests. Over here, fresh whole blood is collected in either EDTA, citrate or oxalate vials. Fresh blood from finger prick can also be used. These are used for detecting falciparum specific histidine rich protein, that is HRP2 and lactate dehydrogenase, vivax specific lactate dehydrogenase and pan specific lactate dehydrogenase or aldolase. Now, these tests, these are very rapid. It allows early detection and it enables diagnosis of cerebral malaria, drug resistant malaria, and therefore, one can initiate prompt treatment. It requires no specialized equipment and personnel do not really have to undergo any rigorous training. It is sensitive, giving you 90% results when more than 100 parasites are present per microliter of sample, and PLDH is produced only in viable parasites, therefore, it helps monitoring treatment. This is what the test looks like. So, usually in the antigen tests you have monoclonal antibody. For the dehydrogenase tests you have the specific antibody which is coated onto the nitrocellulose membrane. A drop of blood is added to the cassette, and if you get the control positive and Plasmodium falciparum line positive, it indicates there is Plasmodium falciparum. If the control is positive and P. vivax comes positive, it is P. vivax. If the control is negative, the test is invalid. In the case of mixed infections, the P. vivax and the P. falciparum line will be positive. Remember, the control always has to be positive for the test to be valid. These are some of the commercially available tests. Serological tests are usually not used in the diagnosis of malaria, but I thought I would just mention These are antibody detection tests, and antibodies can be detected by the indirect fluorescent antibody test or by ELISA, and these only indicate that the person has suffered from malaria in the past, and it is usually done for epidemiological purposes. Coming to the molecular tests, polymerase chain reaction can detect all 4 species of malarial parasites with greater sensitivity than microscopy, and you can see the bands depending upon their electrophoretic mobility. Of course, this test would take approximately 3 to 4 hours to perform, whereas our rapid immunochromatographic tests are much easier to perform, give results earlier, do not require a specialized laboratory or a specialized personnel. Supportive evidence is in the form of an acute form fall in hemoglobin or hematocrit, increase in LDH, increase in the reticulocyte count, thrombocytopenia, and depending upon complications, there may be increased serum bilirubin. In case of renal failure, there may be proteinuria, hemoglobinuria, and increased serum creatinine levels. Coming to the treatment. Now, treatment of malaria can be divided into various forms. If you want to give prophylaxis, you have to give sporonticidal antimalarials, in which we have proguanil, pyrimethamine, pamaquine, and primaquine. For treating liver dominant parasites, remember these are P. vivax and P. ovale, we would like to give primaquine. To get rid of gametocytes, we give artemisinin combined therapy ACTs, which are usually given in patients who are not responding to therapy. Primarily, we will give quinine, chloroquine, mefloquine, amidoquine, or primaquine. To get rid of the parasite during its blood stage, we have chloroquine, mefloquine, primaquine, doxycycline, and in those who have resistance, we would use the ACTs. In India, for treating Plasmodium vivax, we give chloroquine or primaquine. For P. falciparum treatment in the northeastern states, we give artemether and lumefantrine as well as primaquine. In other states, you give artemether with sulfadoxine and pyrimethamine and also primaquine. But usually chloroquine can be given in most cases where resistance is not seen. Prevention of malaria is usually by vector control. Anti-adult measures deal with spraying of insecticides like DDT and malathion or Paris green to get rid of the adult mosquito. Space sprays are also used to get rid of the vector. Individual protection is in the form of wearing long sleeves, wearing socks, using insecticide treated bed mosquito nets, mosquito coils and repellents. Anti-larval measures reduce the mosquito breeding sites, and we can add gambusia, that is larva eating fish, in areas where there is water collection. So, this covers the lecture on malaria. I thank you for being patient and listening to the whole lecture. Thank you.